Let's now take this chapter, wrap it up, and put a bow on it as we talk about allergens. So most allergens are small. They're going to be usually soluble proteins that are present in all this particular matter that we have in the plants and animals in the world that we live. And so pollen grains are very common, cat dander. So the dried cat skin and saliva, typically it's the proteins in the cat saliva and they lick their skin. Feces from dust mites. Sounds delicious. Sounds great to inhale, right? These are very common allergens and they're usually inhaled, right? So symptoms of allergic diseases are often inhaled, or not the symptoms, sorry. The allergens are often inhaled and then they can lead you to these symptoms that you usually associate with having an allergy. And these symptoms, though, are not going to be felt the first time that exposure occurs, but rather it's going to happen during the secondary immune response because specific IgE molecules need to be made, and they're not going to be made until, and also T helper cells and CD8 positive T cells, they're not going to be geared up and ready to go until that primary immune response has occurred. And then these cells are going to be heavily armed with these sensitized cells with IgE on there. And so we call those cells sensitized. So not the first time, but any subsequent exposure that we see, and we've called this a secondary immune response. So here is a typical set of events that occurs with a allergen. First exposure, you inhale and smell these wonderful flowers you get, and it's, oh, these are beautiful. You don't know that you are inhaling these pollen allergens that your body is going to recognize as dangerous, even though they're not. They get in, antigen presenting cells will take up these proteins. And just like what we've seen with the adaptive immune response, antigen presenting cells will present them to T cells. T cells will end up becoming activated. They'll proliferate and end up making, in this case, a T follicular helper cell that's going to convince a B cell that these are going to be terrible pathogens and get a B cell to start producing IgE. IgE is produced from these plasma cells, and then the IgE gets sucked up onto the surface of mast cells and basophils and eosinophils. So the particles get caught in the lining, and that's how they get taken up. So pretty typical pathway of immune response. We've seen this in the past. It's just typically, or what we've seen in the past has always been, instead of being just a peptide that doesn't matter, it's usually a pathogen. So that's the big difference here. But also to note is a T helper 2 response is polarized to make antibody a humoral response rather than a T helper 1 response. Now, a person's sensitivity to allergens can be tested by doing allergy, like tiny little, you take a map of all these different allergens and you do little injections of them and you look for reactions. And so this is allergy testing. When you know you have an allergy and you can't quite figure it out, some of the more common allergens are injected into the skin and you look for what's called a wheal and flare reaction. Wheal and flare means it's going to swell up and it's going to spread out. It's going to be red, maybe red, but definitely spread out. And it could happen immediately, where you get an immediate reaction, or it could happen hours later, which is called a late phase reaction. And that's just where it takes time for those cytokines to be produced, and swelling will definitely then become much bigger than what we saw in an immediate reaction. But it all has to do with histamine being released, histamine leading to the production of these reactions. Histamine comes out because IgEs are engaged. So the physiological effects that we see with an allergen really depend on where the tissue that those mast cells are found in. And so if we're looking at the gastrointestinal tract, The histamine is going to lead to increased fluid secretion, increased peristalsis, which we're going to see as diarrhea. There's going to be maybe some cramping along with that, and potentially some vomiting can happen as well. If we're looking at the airways, those mast cells are going to increase the mucus production. And we're going to see also constriction of the airways is common response to an allergen. And so this can be seen through coughing, maybe sneezing, the development of loogies and phlegm, spitting that out. And then if the degranulation happens in blood vessels, this can lead to a more of a systemic type effect where you have edema, you have, which is swelling, you have inflammation, and then you could potentially have lymph nodes become swollen because the increased flow of antigen towards the lymph nodes. So it depends on which tissue these mast cells are that have the IgE that recognize the allergen. And lots of time that's going to be based on the exposure route as well. So if an antigen, or let's say if an allergen enters through the bloodstream, like a bee sting or a IV drug use kind of thing, those antigens can be distributed very quickly through the bloodstream. It's like a superhighway of movement, right? And because of that, the allergens can interact with lots of IgE on lots of different basophils and cause a systemic response. And we see this as anaphylaxis. It is a very dangerous hypersensitivity situation because so many tissues, so many different parts of the body are affected. And so during a systemic anaphylaxis event, mast cells are degranulated all over the body, and you have widespread smooth muscle contraction. You have vascular permeability, which leads to extreme swelling. Fluid leaves the blood, enters the tissues, and that then drops the blood pressure to drastically low levels because you have a lot of fluid leaving the blood, and that's known as anaphylactic shock. Tissues swell, the kidneys don't get the blood they need, the heart doesn't have the blood they need, blood pressure drops, and it can be a life-threatening situation. So many organ systems are affected during systemic anaphylaxis. The heart and vascular system, the respiratory tract, the gastrointestinal tract, all can be affected during a systemic anaphylaxis event. The most dangerous situation occurs due to asphyxiation. So there can be constriction of the airways, the swelling of the epiglottis, which would then lead to occlusion of the airway and not allow for breathing to happen. Again, we see this in things that can enter the bloodstream, like stings from bees and wasps, injection of drugs, and potentially foods that, although they're going in orally, can quickly disseminate into the blood via absorption. And so really the treatment that needs to be done at this point has to be as fast as possible, and it's usually injection with epinephrine. And so an EpiPen is what we usually call them, but it is an epinephrine shot that will get those tight junctions to close again, to stop the swelling, to keep the blood pressure at a higher level, and then relaxes the constricted muscles in the airways, and can also then stimulate the heart to resume function. So treatment with epinephrine is a life-saving and often very necessary treatment as soon as anaphylaxis sets in. That is if it's bloodstream, right, or orally. But if we see inhalation, it's the most common way that allergens are brought in, and can be like one of the less dangerous, I guess, if you want to level them. Mild allergies can exist due to allergens that are inhaled, pollen, cat dander. You end up usually having some sort of rhinitis, excuse me, very itchy eyes, maybe runny nose, maybe a scratchy throat, often things that we would associate with something called like hay fever. Those allergens get across the mucosal layer. They are taken up by the mast cells, or they're taken up, right below that epithelial lining where the mast cells are. Eosinophils are going to be there as well. Those IgEs are cross-linked and cause degranulation of those cells. The histamine, just like any other area, is going to cause swelling because of the leakiness of the tight junctions. So you'll get some local edema. You might get a lot of drainage out of the nose. If you sneeze or you blow your nose, you can look at that in a slide and you'll see a lot of eosinophils if you're interested. But usually it's not going to be near as threatening as we see with systemic movement of the antigen. You can also get like an eye infection, allergic conjunctivitis, where you get sort of like red, itchy eyes. Much more serious, though, that inhaled allergens can lead to would be asthma. And sometimes people can have chronic asthma where it leads to extreme difficulties in breathing. You can have wheezing, and if that, that can lead to some pretty bad outcomes if the individual that has this isn't put on some sort of like steroid to open those breathing airways, because it's just so tight. And so oxygen isn't getting to the body like it's needed. So inflammation of the airways is a characteristic feature of asthma. And usually this is going to be because of the white blood cells moving in, including the T helper 2 lymphocytes, which will drive a humoral response with eosinophils and basophils and mast cells degranulating and causing tightening of the airways, but also mucus production, which can also further inhibit breathing and making it more difficult. What's kind of crazy about asthma is you can have acute asthma, which can come and go with the presence of an allergen, but chronic asthma can actually develop even when the allergen isn't present. So the allergen can start it, but it can be perpetuated by things that aren't even allergic, like the cold air, or maybe cigarette smoke. And so these chronic events, or not events, but these individuals that have more chronic asthma can be further affected by things that even aren't allergens. The chronic asthma is classified as a type 4 hypersensitivity because it is driven by a T cell response, because there's a T helper 2 response. You can also have some CD8 action in there, but chronic asthma, again, often treated with some sort of steroid to open up those breathing airways. Okay, and allergens can also get in via the skin, right? There can be exposure via the skin, whether it's touching it, which is the most common pathway, or it can also be injected, like if you put this will be touching it, but the metal is put directly onto the skin. They are going to activate mast cells, eosinophils, like we've seen, causes release of histamine, no different than anything of the other slides that we looked at, except for on the skin, this is going to lead to something called urticaria. Urticaria is a fancy way of saying hives. They're just little raised swellings that occur on the surface of the skin. If those mast cells are a little bit deeper into the tissue, the histamine still gets released, but rather than being a raised bump on the surface of the skin, it's more deep, more internal, and it's still swelling. And so angioedema is the example. And there's a picture of the boy here on the far right where swelling has made his eyes swell shut because it's so deep and there's so much swelling going on, because that the mast cell activation. Now, again, like asthma, you can have acute skin issues, but you can also have chronic skin issues with atopic individuals. And usually we'll see this in children. They can grow out of it as they get older, but that's not always the case. And we see this as eczema, dermatitis, and atopic dermatitis or eczema. It's an inflammatory response, but it's going to be more chronic rather than coming and going with the presence of an allergen. It's kind of just there all the time. And these cells are always being activated, and the skin gets red and inflamed and itchy. And we see eczema kind of follow family lines where people have history of allergies. Maybe they have a history of asthma, allergic rhinitis, or having high IgE levels. And the last way that we can see allergens being exposed to the body would be by eating them or by ingestion. So all human food is derived from plants and animals. Plants and animals contain tons and tons of proteins, millions of proteins, and potentially any of those proteins can be immunogenic. We looked at oral tolerance, and typically in normal situations, anything that comes in via the mouth is largely ignored. And the body says, nope, it came in orally, it's fine. The person ate it, that's their fault, whatever. It's not going to be a big issue. But sometimes that's not the case. And as food passes down the GI tract, the proteins are going to be degraded by all the different proteases that we have, and the manual digestion and the acidic digestion. And they're going to get smaller and smaller and smaller as they move through the esophagus, through the stomach, through the small intestine. And any one of these potential peptides could be an allergen. And so people that are sensitized to a specific protein will then be allergic to any food that has that protein. We see allergies more common in certain types of food, like fish, dairy products, nuts, legumes, those are peanuts, shellfish, eggs. We see more often some fruits too. Like I see strawberries a lot. Sometimes that pops up as a common food allergy as well. And the thing with food allergies is that once you're sensitized to a food allergen, any subsequent exposure could actually cause a worse and worse immediate reaction, which, because we know what histamine can do to the different tissues, you can about imagine you can have swelling of the throat, which can lead to asphyxiation. You can have trouble breathing. Local blood vessels are going to become permeable because of that histamine, and potentially you're going to end up with gut issues, and you'll have immediate diarrhea because of that. So cramping can be an outcome, vomiting, any type of reaction that would come about because of swelling or release of histamine that we saw in the other situations. So yeah, typically this doesn't happen, but it does. Food allergies also can lead to skin issues, because of the close association with what we take in our food, and then the blood absorption of nutrients can move some of those allergens then throughout the body, and so they can circulate and they can be transported to other tissues, and other tissues could have mast cells that could be have IgE that are engaged by this antigen, and so you can still have other types of swelling or yeah, anaphylactic type things via eating oral routes as well. And then drugs that you take orally can also be included in this group. Penicillin, if you're allergic to penicillin, that hypersensitivity where it alters this type 2 hypersensitivity, I believe, can lead to an allergy. So anyways, those are the different ways that the body can be exposed. Now I want to end this chapter, and I'm going to end it the way your text ends it, but it's talking about prevention and treatment. Largely, there's three ways that allergies can be, I would say, treated, but actually it's prevention, right? So number one, avoid the allergen. Yeah, easy to say, unless like you like to eat, right? Or you like to go outside, because sometimes those allergens are pretty hard to avoid. So number one, prevention is the easiest way, or not the easiest way, but it's the quickest way to prevent an allergy. Is like, okay, avoid the allergen. But sometimes that can be hard to do. And so sometimes drugs can be utilized to help prevent that. So a monoclonal anti-IgE, want to bind up some of those IgE molecules to prevent them from binding to mast cells, eosinophils, basophils. Probably not the most practical method, but it is a method. More practical and probably the most often utilized are some sorts of drugs that will block the pathway after the antigen has bound to IgE. And so like histamine blockers, steroids to open up the tissues, the bronchial dilators, or suppress the immune system so that there isn't an allergic response. Those are probably the most practical and easy to administer, and probably the cheapest ones to utilize. There is also another way called allergy shots. Allergy shots, this way works pretty well. The issue is that it is kind of an expensive process, but it's also a very long process. And you have to go to the clinic multiple times for a very extended, like could be years, 6 months to a year, maybe more, to get tiny little injections of whatever you're allergic to. Typically, allergy shots aren't going to be used unless there's like a life-threatening, like bee stings is a big one where you get allergy shots for. And what it does is it kind of desensitizes the body to the allergen in small doses, and it actually makes the allergen drive a more IgG response. And if an IgG response is initiated against an allergen upon exposure, then IgE will never get the chance to engage with the allergen, because IgG binds it up, neutralizes it, removes it from circulation. So it's kind of slowly getting the immune system to respond to the allergen differently. Now, these are the approved methods. Let's throw another one out there, though, not approved. And but I mean, it's not too far out of the realm of possibilities. What if we just rewormed patients? Worms, yeah, some of them are pretty destructive, but there's got to be some better ones. Like, let's kind of take that hygiene hypothesis and saying maybe we don't have to be so hygienic in some places, in some cases, right? And we let people get worm infestations and let the immune system attack the worms in a way that it's supposed to and it's appropriate. And then allergies won't be as big of a deal. Now, many reasons not to go this route, but it's an idea. It's a thing. And you can find other people talk about it as well. So anyways, that's where I'm going to end this chapter, this discussion. I hope you got something out of it. Allergies are definitely something that we have experience with. You probably either have some of your own or you know somebody that has them. And so a lot of this is very real to us on an individual level. So there you go. We'll catch you next time.